And we're going to get started in just a moment. Welcome, everybody. I know people are still trickling in, but we've got a lot of content to cover today, so we'll get started. It's my pleasure to be presenting on this topic today with my colleagues. And our topic today is From Systems to Services, Capacity Planning for Older Adult Care in Ontario. And this is part of our Leading in the Care of Older Adults series. So today we're going to be determining current and future healthcare service requirements and planning for an aging population. We'll be discussing that topic. And I'm joined today, I'm Kelly Kay. I'm the Executive Director of Provincial Geriatrics Leadership Ontario, and we coordinate clinical geriatric services in the province. My colleague Adam Morrison is also at the helm today, and you'll see him on the screen. I'm also joined today by Dana Corsi. She's the Regional Geriatric Rehab Lead from the Northeast Specialized Geriatric Centre, and she's an OT by background. And also joining us is Lori Brady, and she's the Senior Clinical Program Director from Unity Health in Toronto. And she also works at Providence Healthcare, and she's a physio by background. And we're really pleased to be here with you today. Before we dive in any deeper, I'd like to take a moment for a land acknowledgement. And I'm speaking to you from Toronto. So in that case, I'll be acknowledging the land I am on. And that is the traditional territory of the Anishinaabe, the Mississaugas of the New Credit First Nation, the Haudenosaunee, and the Huron-Wendat. We acknowledge these peoples because they have a long and wise relationship with this land. We also acknowledge that today, this meeting place is still home to many Indigenous people from across Turtle Island. We're committed to acknowledging the natural world before meetings because it is important to remind ourselves that we're working on behalf of all residents in all places of Ontario, including Indigenous people who have been and continue to be negatively impacted by Canada's colonial history. And just to sort of contextualize this for this topic, the topic of older adults, I want to just acknowledge the many teachings and learnings about elder care and resilience from Indigenous culture that can inform our work together. So the objectives that we hope to convey today and to spend some time with you about are really to help identify approaches to capacity planning that are contextualized for older adults living with complex health conditions, and that can include frailty and dementia. We also wanted to identify sources of information and examples, give you some very practical examples to inform the development of your own capacity plans, particularly if you're working to answer questions about the current and future health service requirements for an aging population. So that's what we're hoping to accomplish with you today. And we're bringing to you three viewpoints of capacity planning. We're three leaders who work at various levels of our healthcare system, provincial, regional, and organizational. And we found as we spoke to each other that we're each gathering information and using planning information to inform the development of plans, service plans for older adult populations. And we're often relying on each other's work. So we thought a session that we brought the three perspectives together would be very helpful to you. And this is really not a theoretical exercise for us at all. This is the work we do every day. So there may be people who are joining today who also have knowledge to share. We invite you to share your perspective in the chat and add to the conversation. So before I get going any further, I'd like to make a bit of a case for a focus on older adults. Now, the fact that you've joined today sort of tells me that you may already be convinced, but let me go ahead anyway. Let's just focus in on a moment with the yellow circle, and that's the population age 65 and older in the province of Ontario, about 2.6 million people. Within that is a cohort that's over the age of 85, about 330,000 people. And this population presents opportunities for prevention of frailty, focusing on activities related to prevention of frailty. On the other side, we've done the work at PGLO to estimate the population living with frailty using a published index. And we've estimated that at the moment, we're at about 640,000 older adults over the age of 65 who could be living with frailty. And this presents opportunities to think it through and plan for the specific requirements of this population to mitigate the personal and system effects of frailty. And I also want to highlight, and our colleague, Dr. Ken Rockwood, who's a guru from geriatrics, he has identified and made the connection between people living with frailty and the high risk of all chronic disease and higher risk of long hospital stays. And this is important because if you think about that, those are both areas that are major areas of focus for health policy. So I also want to spend a little bit of time about thinking about some of the information we have to hand that may or may not be helpful as we're planning. So take a look on the left-hand side here. This is a graph of the age composition of Ontario's population. And what I would like to highlight for you here, this graph goes out to 2046, but in the middle there, about 2031, you can see that the proportion percent starts to level out a little bit. And it might lead you into a bit of a false sense of security that in 8 years' time, things are going to level out and we'll be sort of in a status quo situation. I'd like you to be cautious about blob planning, and that's kind of not an official term. But when we look at a population like that, and we take a very large population, which is actually spanning 40 years, we can kind of run afoul of some of the more effective ways of thinking of planning. When we look more discretely at this population, we can see that in fact, going out to 2046, the population aged 85 is growing at a rapid rate. And so by the time we get to 2046, we'll have about 1.1 million people in Ontario over the age of 85. And that's a considerable growth in the population. So keep that in mind. We did have 65 years to plan for the effect of a baby boom. And I would suggest perhaps we did not prepare sufficiently. So let's not spend the next 8 years hoping that we're going to reach a state of status quo. So why focus in on the population over 85? Well, when we do the work to think through the distribution of older adults living with frailty amongst community dwelling older adults, we see that by the time we get to the age group 85 and older, we have a 52% distribution of people who might be living with frailty. So it's good to pay attention to that particular age group, let alone other age groups within the cohort. I also want to show you this slide on the right-hand side, this image on the right-hand side. I think it challenges a little bit about what we think we need to focus on. For example, recently Ontario health teams have been directed to focus on specific conditions. Heart failure is one example. And when we contextualize this for older adults, we see by the time we reach the age of 80, the prevalence of heart failure is pretty similar to the prevalence for dementia. So I asked the question, why would we choose? We actually need to focus on both. And that becomes a bit more challenging from a planning perspective. I also add this last little case for the focus on older adults in here when we think about falls. We know that falls in older adults are often a signal of other problems, and they really warrant a system that's able to get to the bottom of the reasons behind falls. But take a look at that number right in the middle. My eyes were really drawn by that. $15.3 million a day. If we focused in on falls, we'd actually have enough money to perhaps fund the programming needed to proactively care for older adults. So I hope I made the case a little bit about why we ought to focus in on this particular population. So let's dive in a little bit more specifically to the technical aspects of capacity planning and older adult care. I offer you the definition that's used by the OHA. Capacity planning is a process for determining current and future health service requirements and for making necessary preparations to meet those requirements. And I've touched on that slightly in the information I've already provided. Put simply, it is planning to ensure that the system is the correct size and structured in a way that appropriately meets the population's healthcare needs. And I've highlighted appropriately here because that also suggests you have to understand the population. You have to know something about the needs of older adults to be appropriate. And I think this is where being able to combine clinical know-how and subject matter expertise, as well as the experiences of older adults, really informs that appropriateness. I'm drawing here from a really helpful capacity planning tool. This is a tool that was created by the Rehab Care Alliance and Matthew Meyer. I found it very helpful to explain some of the expectations that I, at a provincial organization, might need to fulfill. And you can find it at the link here, and the entire presentation and all of the presentations you see today will be housed on our website on our events page. So I'm taking the view from here, which is the provincial or the macro level contribution. And so I'm going to share information about the role of such an organization in helping to define and estimate the population. And you can see I've done a little bit of that work. We also work to describe broadly the health needs of older adults living with frailty, and others do the work of really contextualizing that for the local environment and the individual experience. We have to know the actual people that may be living with frailty or experiencing the kinds of conditions I'm describing. We can also, at a provincial level, help to identify resource requirements by helping to explain appropriate clinical services, and we can contribute to data requirements and planning considerations. And you'll see I'll offer a taste of all of that in this presentation. And overall, that helps to contribute to current state assessment and future state capacity plans while supporting the role of other levels of system planning. At the same time, we listen to the feedback that's coming from different levels of system planning to develop common resources, and I'll give you a few samplings of those today. So one of the ways that we help with the defining and estimating of the priority population is in thinking through what we actually mean by frailty. And we've helped to convene a group called the Ontario Collaborative for Aging Well, which really sat down and thought about that and came up with this reframing of frailty to include physical, cognitive, mental, and social health. And why that's important is because when we think about frailty that way, it also causes us to assess for it differently and to come up with different kinds of interventions. We also do the work to help estimate and project the number of older adults living with frailty, and we've done this work out to 2040. We'll be publishing very soon the most recent census data on our website, and we break this down by census division so that you have the opportunity to do some calculations in your own communities. The other thing we do is try to describe the health needs of older adults. We did work prior to the pandemic, looking at the population through administrative data to give a bit of a sense of what older adults might be living with. And you get a sense of that on the left-hand side. Since the pandemic, we're also aware that older adults are facing the impacts of increased anxiety, depression, and sleep disorders, as well as the impact of decreased physical activity. Further, we know that older adults who really were impacted by COVID-19 may still have persistent symptoms or outcomes as a result of that infection, and the potential impact of persistent fatigue on their activities of daily living. And as well, having been so dramatically affected, older adults are living with trauma and grief, and something we don't often talk about, but it certainly has an impact. We also know that older adults are experiencing increased morbidity due to delayed or foregone care. And we've heard anecdotal reports from our clinical community about increased psychosis among people who have become socially isolated. And there's other emerging requirements. And so this starts to tell us what we might expect to see and what we should start to look for as we're meeting people face to face, one-on-one. We also can help to organize from a provincial level some of the thinking around resource requirements, and that includes having essentially four broad categories, and there may be others, feel free to comment, but things like community management, how are we supporting older adults in the community, and that can be with a focus on frailty prevention, early identification, screening and assessment, as well as palliation. We need to have a mechanism for urgent and emergent response, and that would help us include focus on rapid geriatric assessment, having mechanisms to facilitate admission diversion, so other places to go to receive care, as well as admission support with a senior-friendly and goal-based care plan. And once using acute care, we need that acute care to be taking up the best in senior-friendly care principles and to address that acute decline or injury in a way that is sensitive to the older person's needs and supports a transition to an appropriate destination. And as well, threaded throughout, we need to think about rehabilitative care, which really helps to preserve and restore function, and that ought to be delivered according to goals of care and provincial guidelines. And a few examples of all of those have been thought through as well. And these are the sorts of things that you could anticipate from an organization operating at a provincial level to help to think through where those examples might lie, with whether they be within Ontario health teams, within GEM nurse programs, within consultation liaison teams in the acute care environment, or in various rehabilitative models throughout the system. The other thing we can help to do is support the data requirements of planning. And we can do that by collecting information through service inventories and asset inventories. And that's something that we do around specialized geriatric services. And I know many Ontario health teams are involved in similar work as they carry out their current state planning. So we collect information about the location and the type of geriatric services that are on offer, as well as the full-time equivalents and the service volumes currently being provided. And further, we can think through together what other data requirements might be necessary. And so this is an example where we've done this, where we took the original 122 indicators put forward by 42 Ontario health teams back in 2021 and grouped those according to 6 themes. We had done some previous consensus indicator work in collaboration with older adults and clinicians and researchers working in the field of older adult care. And we matched up the themes with possible consensus-derived indicators to offer a series of indicators that Ontario health teams might want to consider for the next CQIP. We adjusted the wording to contextualize it for the Ontario health team environment, and then we also added new fall-related indicators that have been recently published. So this subject matter expertise helps to keep current with the kinds of information OHTs may need to take up and use. And here's an example of that. This is sort of ripe for a screenshot if you wish, and don't forget the presentation will be available. So this is an example of how indicators can be identified that might align with what OHTs are hoping to focus on. The other thing we can do is bring together planning considerations, and these sorts of considerations come out of subject matter expertise and the various forms of feedback that we have access to through the course of our work. One of the things that's most important that we start off with when we think about planning in this context is we don't call older adults frail. They may live with or experience frailty, and it may be reversible, but labeling somebody frail has real consequences, including a sense from older adults that health professionals are giving up on them. And while we're at it, let's not call our parents, grandparents, and future selves ALCs or beds either. We can also plan for proactive care. So if we think about the fact that we provide quarterly diabetes care visits, we should be thinking about treating multi-morbidity at least as proactively as those accepted clinical standards. And I'll give you an example of what that looks like in a moment. We also need to recognize and respond to waiting and collect broad service wait time data. And why that's important from an older adult perspective is older adults may be referred to multiple services and have to wait for them all. So we need a sense of what, the cumulative effect of waiting. We also need to assess for palliative care needs. So this has implications in terms of how you connect the dots between people living with frailty and palliative services. We should also be questioning the data when it comes to older persons' care. What is excluded? In the first pass of the attributed populations data, we excluded sites such as CHCs and nurse practitioner-led environments. But those are sites that serve people who live with complexity, and that can be the older adult population. So we may be underappreciating the older adult population. We also may not be tracking or collecting all the comorbid diagnoses when someone's admitted to hospital. Many times someone may be admitted with a fall or a fractured hip, and we don't actually capture the fact that they have dementia. So we don't get a true sense of multi-morbidity. We also need to think about how ambulatory sensitive is being conceptualized. If we're not using frailty modifiers in the collection of that data, I just offer you this particular note that, well, frailty is characterized by the body's inability to cope with minor illnesses that would normally have a minimal impact. And so it becomes a bit nuanced when you start to label such problems as ambulatory sensitive. We do need to avoid the frail, non-frail binary. It's a bit aligned with blob planning. It's not as helpful as understanding degree of frailty, because once we know degree of frailty, we provoke different tailored responses. And I've got a link here to a resource that I'll put in the chat afterwards about an example of how that's been done. And generally, let's think about alternate level of care as meaning frailty. For clinicians, frailty is a more helpful planning construct than ALC, because it actually starts us thinking down the road of appropriate clinical service design and clinician response. Just got a couple more tidbits for you here, and I'll be passing the torch pretty soon. This is just a bit of a thought exercise here. So when we think about the actual number of frailty-focused visits provided by specialized geriatric services, and that's in the green, and of course, that's not all the frailty-related care that's happening, it's just an example. And we think about where we want to be, which would be if we just do the simple math of multiplying the number of older adults living with frailty by 4, so that we provide at least 4 visits a year. You can see the delta is quite large. And so when we think about our planning and where we see how we'd like to conduct a current state assessment, these kinds of thought exercises could also be helpful. This is just an example, and I've got 2 tools. This slide and the next slide are 2 tools that I'll leave with you. Feel free to grab a screenshot of them, and of course, you can refer to the deck afterwards. But when you're looking at clinical pathways, you may also want to analyze them from the perspective of whether or not they would help you achieve care for older people living with frailty. So we've just created a simple mnemonic here that could be useful. The next slide is a bit of an eyeful, but I just want to show it to you as an example because it's a rubric that we've created. It's been informed by work that we did around design elements for integrated care. So we've done the work to examine the literature to pull out design elements that could support the development of integrated care and turned it into a rubric. So these are the sorts of tools that you can expect from an organization like a provincial organization to support planning at different levels. And so I've given you a bit of a taste of one of the 3 viewpoints of capacity planning. And I'm going to turn it over now to Dana, who's going to walk you through how she's been going about regional planning. So I'll stop sharing now and Dana's going to take over.
Thanks so much, Kelly. I'm just going to share my screen. And if you can just, oh, wait, you can see, okay, perfect. Awesome. So excited to talk about this. All things that Kelly has introduced us to from a regional context. And really, it segues beautifully from what Kelly talked about in terms of the opportunity I'm going to liken this to regionally, because we're going to talk about ALC and then think about how that gets put into practice at a regional level. So here we go, maybe. Yes. So just for some context setting initially, I think, I saw lots of folks on the call, colleagues from other regional geriatric programs, and I think it's important to just level set in the regional space that I come to you as someone who works as part of the regional geriatric program in the Northeast, but there are multiple programs across the province who can support this work wherever it may be happening. Kelly provided us with the provincial structure. I really want to dive deeper into that regional infrastructure that exists and how we can support this capacity planning at a regional, sub-regional, and support what it looks like across the system at a local level. So from a Northeast Regional Geriatric Program perspective, what does this look like for us? So we're Northeast Specialized Geriatric Center. You can see our geography on the left. We really provide strategic and operational leadership for the implementation of clinical geriatric services across that region. And we support partnerships, we support local community and health partners to achieve this in many different capacities through many different mandates. And ultimately what we're looking at is that are individuals, older adults who are living, as Kelly shared with us, who are living with complex and chronic health and social care needs, so frailty. And we're not only supporting them with delivery of that specialized care. So those folks who have the highest needs or the most complex needs, but we're also supporting the system to enable shared care for those who have a moderate level of complexity or higher need, and also to support primary care as, you know, a key system or a key point within our system to support care for those with lower need or less complexity. But generally, we're focused on those specialized geriatric services that meet the needs of older adults. And so when we think about how do we plan for that capacity across a region, I'm going to walk us through the same approach that Kelly led us through in terms of a provincial structure, but really think about how that applies at the regional level within the context of population, care needs, clinical services, looking at a current state assessment, other planning considerations, and then future state capacity planning. And all this to say, I'm going to use the example of alternate level of care. Alternate level of care is not a new thing, but the energy and attention that it is getting currently in terms of investments, in terms of recognizing where we're at as we come out of the pandemic, is really presents an important opportunity to leverage with respect to capacity planning for services for older adults living with or at risk for frailty. It's a provincial priority focus. It's also, we've moved away from, even though ALC is measured in the hospital, we've moved away from it being a hospital only problem. We are thinking of it as improvement must extend the continuum of care. So what does that look like from a system approach? How do we think about this a bit differently? As ALC impacts everyone. It impacts providers, it impacts the system, but most importantly, it impacts people. It impacts older adults, their caregivers, their support system. So how do we think about this more broadly? And likening it to this investment that has recently been looked at across the province in terms of ALC initiatives, and thinking about capacity maximization, admission diversion, discharge supports, and additional local strategies. So adding capacity to the system in these different ways in order to support addressing ALC from a system perspective. So in the Northeast, I'm going to speak to capacity planning in terms of these ALC initiative investments and how the work that we routinely do as a regional geriatric program in terms of capacity planning for older adult care for those living with or at risk for frailty has really helped to inform the planning efforts of our local regional Ontario Health folks with respect to this initiative. So the population, broadly, what we know, and Kelly led us into this with ALC and frailty piece, but to provide you with some additional data and evidence, what we know about who is becoming ALC and who is most at risk is that, number one, the majority are over the age of 65, and there's increasing risk noted over the age of 75. In Ontario, what the data tells us is that 80% of all ALC designations are for folks over the age of 65, with the largest cohort, 64%, being attributed to folks over the age of 75. Age is one variable, but it's a key variable when we start to think about understanding that population. When we look at additional common characteristics from the literature, from the evidence, what we also know is that folks who are most at risk have an admitting diagnosis that includes general medical issues or illness, falls, and dementia. Dementia being one of the most prevalent across the board. Presence of functional or cognitive impairments and multiple comorbidities, and the experience of adverse events during admission. So functional decline, delirium, falls, social isolation, and of course, caregiver stress. So sounds familiar, right? It's very, very consistent to what Kelly just led us through in terms of the population. So what does that mean at a regional level? Because great, we know that provincially, but how do we start to think about what this may look like in the Northeast? And then for folks on the call, how do you apply this to your specific region in Ontario? So the way that we did this was, a couple of ways. Number one, looking at and understanding the age cohort that is becoming ALC in our region, we looked at the data, and as you can see across the entire Northeast as an aggregate, 85% of all ALC designations are for folks over the age of 65, and a very consistent number for the cohort who are over the age of 75. But again, Northeast is an aggregate. So how do we start to look at those subregions within the region to see if there are any differences, to start to understand what that might look like within that context? And again, there's some variability, but in general, the proportions are high. And in general, the proportions are higher than the provincial average. So that's important for us to know as we start to think about where we need to go with this. Secondly, we took a look at ALC open cases. What are people waiting for right now? And how do we just keep that in the back of our mind? So we know, again, as an aggregate, 25 hospitals, 434 open ALC cases as of January 12th. And we can see that almost half of folks are waiting for long-term care. The next two highest cohorts are waiting for a level of rehabilitative care and waiting for care at home. But when we start to drill down, what is interesting is what is the variability in the more sub-regional context. The places that I focused on, in order to present the information are really what are the priority locations for funding for the batch one, so the first round of funding. And when you look, you can see that it's really different depending on where you look. We have multiple locations where rehab is the predominant location of care that folks are waiting for. Others, it's all long-term care. Okay, so this is a starting point again. Where else do we need to look? What questions do we need to ask? And then we looked at the case mix group. So great, we know age, we know what care people are waiting for or what destination they're waiting for, but who are these folks? What are they coming into hospital with? We know that ALC is measured in the hospital. So what is it they're presenting with that, is resulting in an ALC designation? Well, when we look at it, and we look at, again, Northeast as an aggregate, we see that the top 10 case mix groups, which, is based on discharge information, it tells us the most, basically the most responsible condition for their admission. What we see, dementia, falls, weakness, frailty, that's a rename of the group that it actually is. Hip fracture, delirium, so on and so forth, account for almost half of all ALC days across the Northeast. We start to think about people, we can start to imagine people who are becoming alternate level of care. The key here is that these top 10 case mix groups vary at a sub-region and local level. No surprise, as we saw with open cases. But a key piece to keep in mind is that regardless of the location, regardless of the sub-region within the Northeast, dementia, falls, weakness, frailty, and delirium were consistent across those priority locations. They're showing up consistently. It gives us a really good idea of how we need to look at capacity planning for this. And then finally, just to echo what Kelly said, we are here. We're at a point where we're just at the tip of baby boomers becoming older, and we know that we're going to see exponential growth over the next 17 years. We're going to see it across our subregions in the Northeast. So it's important to plan for today with these investments, but the planning is really about moving forward and thinking about how we build the system we need for down the road for folks like myself as I move into that trajectory. Okay, population. We spent a lot of time there, but you'll see why. Population informs everything. We need to understand the population to really be able to then address the care, identify what the standard of care is for the population, as well as what the services are to meet those care needs. So, I'll touch briefly on this. There is no regional variation that goes with this. This is what we need to do in the Northeast and how we've approached it. We know the standard of care for older adults. You see that on your right. It's echoed in many provincial clinical guidelines, from senior-friendly care, which is essentially the foundation of all care for older adults and is really diagnosis agnostic. It's universal design for older adults. But then we speak to other specific provincial clinical guidelines, but they still all align to this common standard for older adult care. Including the one that I'd like to point out is the alternate level of care leading practices, which contain all of these key pieces in terms of the standard of care for this population. Next, clinical services. Again, Kelly talked to us about the asset mapping and the types of specialized geriatric services. I just want to point out that as we plan, when we do capacity planning for older adult care in the Northeast, we build from that provincial cohort or snapshot or inventory of what those clinical services are. And we use the provincial definitions based on this listing of services across the continuum in order to maintain a common language and a common consistent approach to how we are implementing care, regardless of where it is across the continuum. So this is our go-to, this tree, in terms of understanding what these services could look like and should be according to our provincial guidance. And what does that mean in terms of current state capacity? So we know the population, we know what care they should get, we know what it should look like in terms of services. Well, what we did and what we've been doing in the Northeast is keeping tabs on what this looks like across our geography. And you'll see I've given you a representation of some of those services that are on the tree. And you can see, again, the yellow highlights are those priority locations. You can see where we don't have access to specialized geriatric services. And it really paints a picture about the availability and the access to the care that is needed for the population and where we might have opportunity to start. This is just one piece though. This tells us what we have, what we don't have, what are our levers in terms of thinking ahead to adding service. But the key piece is the planning considerations and those resource requirements that Kelly talked about. How does this all go together? It's one thing to have a service, it's one thing to add capacity, but it's another thing to connect the dots for that capacity. And those are the key questions that we're asking from a regional program level of all our subregions and all of our locations as we move forward with this. What is the current scope of each service? How do we understand who is part of your team so that we can connect the dots, so we can speak the same language across the continuum of care here? How are folks identified? Kelly mentioned that. How does each service's assessment support identification? How does it speak the same language? What interventions are provided? How do we bridge transitions such that they aren't the typical transitions we experience across care? How do we connect the dots between all of those services? It's not just about adding service. If I say one thing, I'll say that it's how do we connect it across the continuum? And then finally, what does our future state capacity planning look like? If we know how it's all connected, we know what the opportunities are in terms of what's missing as we see here, we know more specific data about the population, then we can make recommendations about where we want to start to add care. And we can know what the definition is, we can know what the common components of that care are, so that when we implement GEM in Sudbury or Parry Sound, it has a consistent approach to how we implement it in Temiskaming or Algoma. And it connects directly to the inpatient geriatric consult team that we're looking at implementing in North Bay or in Sault Ste. Marie. So speaking the same language, adding capacity, but ensuring, again, as we do it, that we're building forward and enabling future state integration as we do that. So that's it for me, and excited to pass it off to Lori as she brings us down to the most important piece in terms of the organizational level, and I'll stop sharing here.
Awesome. Thanks so much, Kelly and Dana. It's tough acts to follow. I'll start by initiating a screen share on my end. Maybe Kelly, if you could give me a thumbs up just to confirm you can see that purple screen. Awesome. Wonderful. So yes, I think this is the third leg of this race here. We've taken it from the systems, provincial level to the regional. And now I'm really here to speak to, at the organization and program level, what capacity planning can potentially look like and what outputs it can offer. So as I mentioned, I'm really wanting to walk through our approach, our local program approach to capacity planning that we undertook within our specialized geriatrics services about a year ago. We'll walk through that program level review and the prioritization exercise that we undertook, and ensuring that we have a good idea of the inputs that were considered into our recommendations. Before I get into those details, I just wanted to situate you all as to where we are, where I am. So Unity Health Toronto is the organization in which our specialized geriatric services are located, and specifically at the Providence site. But just to let everyone know, Unity Health is a multi-site organization which spans Toronto from the east to the west. And all of our services really encompass cradle to grave type services, but more specifically, I'm referencing the Providence site. The Providence site in the east, it's comprised of a post-acute site. We have a rehab hospital as well as a long-term care home on our campus. On the hospital side, we see almost 3,000 admissions on an inpatient standpoint, almost 5,000 on an outpatient standpoint annually. And we have almost 300 long-term care beds and 231 budgeted rehab and CCC beds. We have a history at the Providence site of admitting and seeing those with the most complex rehab needs, the lowest FIM scores, functional independence measure scores, and discharging them with the greatest gains that they have made. And the majority of our patients are discharged home, thereby oftentimes requiring outpatient supports, which we offer. Specifically related to the specialized geriatric services program. Here's that tree yet again, which shows all of the basket of SGS services across the province. However, at Providence, we have services under the umbrella of inpatient geriatrics, other outpatient-based services, and community geriatrics. So more specifically at Providence, we have a day hospital, a geri medicine day hospital. We have our outpatient clinic in the areas of geriatric medicine. We have our outreach teams. And from an inpatient perspective, we also have our GAT2 beds, geriatric assessment and treatment units, embedded within our geriatric rehab and medical programs. And our inpatient geriatric consultations, both from a geri and a geri psych perspective. And this is our local catchment area for this program. So as you can see, we're nestled right in the heart of Scarborough, and our catchment area spans the majority of Scarborough, but heading over into West Toronto, East York, a bit north of Steeles into the Markham area as well. So a fairly widespread reach for a local program in specialized geriatric services. We had realized that it had been some time since we had taken a look at the program from an annual program planning standpoint. We also recognized that at the Providence campus, we were on the heels of a campus of care redesign and campus planning. So the thought was that we wanted to get ahead of that campus redesign planning and ensure that for this program, we were looking at the capacity data and information at multiple levels, provincial and regional, and we're poised to offer some recommendations specific to our own specialized geriatric services that could align with and feed into that campus of care planning exercise that we were undertaking. So our review, I would say, is a multi-phased set of work, but in essence, I wanted to unpack and offer details around the phase 1 exercise that we undertook. So our objectives for phase 1 of this work, which occurred last year, were to really do a deep dive review and prioritization exercise for our specialized geriatric services. And as far as outputs, we were hoping to land on long-term strategic redesign and growth opportunities for us. But at the same time, we also thought landing on some QI opportunities for improvement were objectives that we wanted to include as well. So that, in essence, is what we set out to do with a cross-functional project team, including frontline team members from our clinics, our outreach teams, our inpatient units, as well as representation from the patient and community level. So we had a patient family participant sitting on our project team as well. Our project, we endeavored to span about a 4-month duration. Of course, at the time, the various waves of the pandemic made it difficult to undertake strategic planning activities and exercises. So there were some delays, but ultimately we were able to wrap up. The inputs you see on a high level represented on this slide. We really wanted to look at provincial level data as well as regional data. We wanted to look at local program metrics, and as well, we wanted this to all be informed by the direction of the patient's voice. So we looked at our patient experience data wherever so they were possible. So just a few highlights in terms of the data sets and the types of information we considered. With regards to our local data, you see the couple of data points here. I do want to pause and highlight that there was a dedicated effort to ensure health equity data and a review of our local program health equity data was incorporated into our planning. And as well, I'll articulate how we leveraged the provincial level asset mapping information to better assess how we were performing at the provincial level and as well relative to our peers. We really used it to situate ourselves provincially and locally. So I won't go through this slide in detail, but you all know that Kelly and team put out amazing reports, which are used at the regional and at the local program level. So I'll perhaps speak to a little bit of what we did with this information. So that PGLO asset mapping report from the previous year was actually useful in helping us to answer a few questions. We pulled the data from that report, our own data, but also the data of other SGS programs within our region, and mapped out how our Providence SGS program was performing relative to provincial numbers, and as well how we were performing relative to our peers within the Toronto region. And so an example of that would be with regards to visits. Of the visits seen in the geriatric medicine clinic, for example, what proportion of our visits were seen relative to all of the geri medicine clinic visits seen in the province? What was our proportion, whether it was 12%, I believe, if memory serves correct. And then how was our proportion relative to other local SGS programs? Were we seeing the lion's share? Were we seeing significantly less? And were there reasons and drivers as to why that was? So those that information led to some of these subsequent conversations where we were exploring what our current performance was and where there were opportunities for us to better capacity plan relative to our catchment area's needs. We also looked and asked ourselves some crucial conversations around our service types, looking at what we do offer with respect to SGS services, but equally importantly, what we don't offer. And is there a rationale as to why we should continue to not offer those? Or are there other areas where we should look to evolve towards, whether through direct service provision or potential partnership opportunities? Another significant step in this process was ensuring strategic alignment at multiple levels. So certainly at the Unity Health Toronto corporate level, at the regional level through the RGP Toronto, at the provincial level through bodies such as the PGLO, nationally and also globally. So we did a bit of a scan and pulled the research and priorities, and again leveraged a few resources on the PGLO site to do so. So I'll conclude by sort of showing you a summary of where we landed. We had some crucial conversations around stop, continue, start, or expand. And I won't go through service by service, but just to give you a snapshot of the outputs and what we landed on by way of opportunities that we wanted to continue with, perhaps expand further, or perhaps in the future think about starting based on, again, the provincial level data analysis, our local regional capacity relative to other programs adjacent to us and our catchment area and our patient population and their evolving needs. Our overarching recommendations were on the area of redesign, potentially for our outreach programs, and potential growth for a few of our clinics that we have, be they Geri Med and Geri Psych. And then just to conclude with some lessons learned, I know we want to have some opportunity for dialogue towards the end, but we thought it was important to have a patient or family voice at the table as to inform this planning. So an older adult who had been through some of our programs were included as a part of the project membership. We wanted to ensure that our frontline team members were positioned as subject matter experts and leveraged to bring their perspective to the table. And so they also existed and informed the process. As I mentioned earlier, the health equity data was extremely important to consider. And we tried to ensure innovative ways to leverage or to engage, individuals, given the nature of virtual meetings and discussions. So all in all, I think we landed on some strong outputs to better inform the development of our upcoming operating plans associated with our campus of care expansion. We also decided on some tangible shorter term investments, such as a CNS clinical nurse specialist for seniors health, to better help integration and support the program internally as we got to the point between now and the future. But ultimately, this was a very worthwhile exercise in which we were able to take provincial level data, cross-cut that at the regional level, and assess it and compare it with how we are currently performing and where we as a program are hoping to go in the future. I'll pause and stop my screen share. And maybe Kelly, I'll turn it back over to you, and at the same time scan the chat to see if there are any questions for me.
Thank you, Lori, and thank you, Dana. I think you've really brought home the point about how we take up and use information and how we make sense of it at a very localized level at the place where we're actually interacting with real people. So I really thank you for putting together these incredible presentations. That was a lot of work, and I just find it so valuable to see how what we think about in one context transpires into real action in another. So I'd like to open it up to the group and invite you to share your reflections and thoughts. And I noticed we've had a bit of back and forth in the chat. I certainly want to highlight that we've been focused around a particular aspect of capacity planning, and the services that are within our span of control are related to clinical geriatric services. But that's not the totality of what's required to support older adults to remain living at home. And I see a number of community partners on the call today. And so let's think together too about what are the opportunities for us to join forces. And I think the OHTs provide that venue perhaps for us to think collectively about capacity planning more collaboratively. So thank you for that note, Rachel. That was a really good point. Mary's asking, how do you all link to prevention of frailty and pre-frailty? So thanks, Mary. I appreciate the question. Maybe I can start off and think about and share what we've been doing in this area, and then Dana and Lori, feel free to add. One of the key ways that we've been thinking about frailty, prevention of frailty or pre-frailty, is through the work of the Ontario Collaborative for Aging Well. And that's a group that has come together rather organically to ask that very question. What can we be doing within a community context to help older adults avoid becoming frail altogether? And we've really capitalized on the work of the Canadian Frailty Network, who have created a whole framework that they call AVOID, the Avoid Frailty Framework. It's an acronym, AVOID, and it stands for activity, vaccination, optimizing medication, interacting, and diet. And so that information is on the website of the Canadian Frailty Network. And then what we've done is taken that and considered how we can contextualize that within an Ontario environment and within Ontario health teams. And I'm not sure if we're joined today by our colleagues from the Kawartha Lakes Family Health, the Kawartha Lakes Ontario Health Team, but what they've done is they've actually taken up and created a whole program around supporting older adults to take up and use the information from the Avoid Frailty Framework and begin to engage in activities that really do that job of avoiding frailty. So if you haven't had a chance to check that out, I invite you to do that. Dana, Lori, any comments on Mary's question around prevention of frailty, pre-frailty?
I think I would just add, in keeping with the theme of the regional presentation, when we look at alternate level of care, there's been, and PGLO and the RGP of Toronto with their senior friendly care work have led work to develop community-based leading practices that have a priority focus on ensuring that all folks, whether it's the mailman, whether it's a business, whether it's a healthcare provider, social care provider, are familiar with frailty and how to think about leveraging services, whatever they may be, to prevent frailty. So it's not just about the downstream as someone presents with frailty. It's that entire continuum before. So I think tying it into all of these initiatives that are of priority focus is one example of how to link not only from a system perspective, but also from a care provider across the continuum perspective.
Thanks, Dana. Lori, anything to add?
Yeah, I'll just add in one quick notion that I think this is definitely something that, an issue that we do see, particularly given our cross continuum of services and the fact that we've got both an inpatient scope and an outpatient as well. We've really tried to work from a partnership building and development perspective to work and address things such as frailty through our Ontario Health team that Providence is a partner on 2 OHTs. So working with our OATS partners specifically on this very same patient population, frail seniors, and how we can get upstream through partnership work to be able to address and prevent frailty as it comes. So I think just leveraging our OAT partnerships have been really an innovative way for us to collaborate as to how the prevention efforts can continue beyond, I would say, the hospital walls, which it rightly should.
Thank you. We've got a good question in the chat, and I'm going to invite others to comment as well on Tammy's great question. Can anybody comment about access to personal health information across sectors if various systems cannot access patient information? It hampers care delivery. It's an excellent point and a continuing confounder in our system. I know that our OHT colleagues are working hard on that, so I would invite you to add to the chat about that. I would just really reinforce, I don't have an answer for you, Tammy. I really just to sort of say there is no getting away from knowing the person in this work. I, at a 60,000 foot view, can only, as you can see, can only do so much to interpret what is required on the ground for an older adult population, but you actually have to know the people and their individual needs. And so I can only reinforce the struggle that you've identified, Tammy, that we've got to find a way to get around that. I know there was early work in the days when HealthLinks was kind of an active file to try to come around those questions and issues. And I'll just ask if Lori or Dana have any other insights around this real challenge about really sharing information so we know specifically what people really need. Oh, kind of the same status quo, right? Good question, Tammy. Jury's still out. Eleni, thank you for the questions. How do regions balance investments between upstream and downstream interventions? Oh, that's a great question. Maybe we'll turn that to you, Dana. What do you think in the last couple minutes here?
It is a great question. So I know my colleague from Ontario Health Northeast, Jennifer Willenius, is on the call. And please, Jennifer, if you have some insights, please jump in. I think from an RGP perspective, I would say it's about understanding within the sub-region context or the more local system where those pressure points are. It may look different in each place what that investment is in order to counter that need. We have some places where long-term care home beds have been closed, so you see a different pressure than in a place where that bedded capacity is sufficient, but access to geriatric care and primary care is non-existent. So I think it's really understanding that current state in the local context to be able to end the pathway across in order to balance it respective to each subregion. That's my general gist.
And maybe I could just offer that, I've observed what's been happening with our colleagues in the Northeast and the collaboration between those that are planning for older adult care and those that are delivering care. So the relationship between Ontario Health and organizations like the one that Dana works for, as well as other partners. And my observation is that the conversations are actually facilitating the balancing act, because it's sort of stimulating buy-in as people grapple with these challenging questions together. Then no one's left sort of with the accusatory finger of you made a bad decision here, you made a bad decision there. So I think those conversations have been really essential, and I wonder if you would agree, Dana.
I 100% would agree. And I think just based on what you said, I think the other key piece is in order to get a better understanding, as we have the conversation, it's essential to have folks who receive care and their caregivers present to share that experience of what it's like, because what it is on paper and how it actually comes to fruition and happens across the board, we only know that from the perspective of folks who experience and folks who deliver. So
thank you. Any last thoughts, Lori, before we break? No, very good.
Yeah, I am. I think this was a welcome opportunity to see the juxtaposition of the provincial, the regional, and the local organizational level.
Well, thank you both for joining me and presenting today, and to all of you who stayed to hear this presentation. The links will be made available on our site, and you're welcome to share. And please continue the conversation. Thank you very much. Bye-bye.